Well, I'm going to introduce Rory Akers, who is a ERISA lawyer with Lockton Dunning Benefits. She's got a number of years of experience. You should know that she used to work as a senior investigator with the U.S. Department of Labor. Many of us have been opposed to them many times, so I'll try to be polite when I talk about her prior experience, where she certainly learned everything from the government's view about ERISA and the Affordable Care Act and HIPAA and the Mental Health Parity Act, which I think she's going to talk about some today. She's been with Lockton for a good period of time. She is a lawyer, and hopefully she can tell us how to understand the maze that is some of the ERISA and mental health complications and what the government really wants from you. Okay, Roy.
Well, thank you, John. And I'm going to try my best. But I think what you will learn as I go through my next few slides here in the last few minutes we have today is this mental health parity is more complex than I think even the government knows at this point. So as John was so kind to state, I've been with Lockton for some time as a senior compliance attorney, but I did hail from the Department of Labor. And in fact, I was involved with some of the investigative planning as we started looking at mental health parity laws. So I have some insight into what the DOL may be thinking at this point, although, people in government change. And so views may change as well. But the one thing I want to highlight very quickly is mental health parity has gotten a lot of press lately, mainly because what we'll talk about later, its inclusion in the big CAA package that was pushed out late last year, that massive Consolidated Appropriations Act, where they highlighted a mental health parity requirement that we'll talk about a little bit later. And I think that spurred a lot of conversations as to, oh my gosh, is our employee benefit plans in compliance? But the rules aren't new. The mental health parity rules that apply to employer-sponsored group health plans actually have been around in some forms since the 1990s. So I'm not going to go through this slide specifically, but it started as a simple requirement that if you provide mental health and substance use disorder benefits in your employee benefit, you have to treat them the same as medical surgical benefits. Now, the one thing that I think is important to note is the mental health parity rules are not a mandate for employee benefit plans to, in fact, provide mental health and substance use disorder benefits. But if you do, you are in the bucket of having to comply with mental health parity rules. So the rules have morphed over some time. And currently where we are is it's the Mental Health Parity, Addiction, and Equity Act. And basically, in the highest level, what it says, it got a little bit more specific with requirements. If you provide mental health and substance use disorder benefits, so again, if you provide them, you have to make sure that those mental health substance use disorder benefits do not have separate annual or lifetime limits on it. You also have to ensure that any financial and quantitative treatment limitations, so those are things like co-pays, deductibles, any sort of visit limitation, you have to ensure that those are on par or similarly applied on the medical surgical side. And then the third bucket we're looking at here is what's called non-quantitative treatment limitations. So those are high level, anything without a number that you require a participant or a provider to do to get mental health benefits. So those are things, if you think about pre-authorization requirements, medical necessity criteria, the determination that maybe a treatment is experimental or investigational. So those behind the scenes requirements that a plan may impose in order to get benefits paid. So the mental health parity rules look at those three buckets that have to be analyzed to ensure plans are in compliance. The other thing is you have to look at each bucket within a specific classification, which I have highlighted there on the slide. You have inpatient in-network, inpatient out-of-network, and you guys can read that. So as you look at each of these limitations, you have to bucket it within one of those classifications to determine if parity exists. So the $1 million question, well, how do you determine if it's in parity? So I'm going to highlight quickly here quantitative treatment limitations first. And the reason I'm going to do that is one, I think these are relatively straightforward. There is an objective mathematical test that comes into play to determine if a benefit or a quantitative treatment limitation applied on a benefit is in parity. Now, I say that there is a pretty straightforward math problem, even a math problem that Rory Akers can do. And Rory Akers went to law school because she's terrible at math. But there are some nuances that come into play specifically of how you bucket claims to do the math problem. But in order to determine if one of these quantitative treatment limitations is in parity, so I'm going to use an example. We're going to look at a copay. I'm going to highlight this one because this is the one I think the DOL cites still most often is if you have a primary care copay and then you have a specialist copay. And what some plans will do is for mental health benefits, they will apply the specialist copay that's usually higher than that primary care copay. So if you consider that, okay, that's a quantitative requirement on these mental health benefits. Do we have the appropriate level in place? Can we charge that higher specialist copay? And so it's a two-part test. First, you have to show that the actual benefit or the actual copay, not the benefit, the actual copay is applied to at least 2/3 of all of the benefits in that same classification. So the ones we highlighted in that same slide or the prior slide here. So for copays here, we're looking at outpatient visits. So do we apply a copay to at least 2/3 of the medical surgical benefits in that classification? If the answer to that is yes, then you have to go to step 2 of this math test, which is what is the copay limit that is applied to at least half of those medical surgical benefits? This involves looking at claims data. So if we do an expected claims analysis of the plan, you do the math problems on that expected claims math or value. If the specialist copay is the one that is applied to more than half of those medical surgical benefits, then you could apply that specialist copay to the mental health benefits. But if what the math test shows is actually that primary care, that lower copay amount is the one that is applied to more than half of those medical surgical benefits, then the test would say you have to apply that lower amount to mental health substance use disorder benefits. So again, it's a math test that comes into play, straightforward math. If you get into the details of how to bucket claims, it becomes a little bit more complicated, but that's the analysis for that portion. Non-quantitative treatment limitations, that's a little bit harder of an analysis. And I've highlighted the steps that the Department of Labor has said come into play when determining if a non-quantitative treatment limitation is being applied appropriately under parity laws on those mental health benefits. And so, it's a step-by-step process. You identify the non-quantitative treatment limitation. Let's say it's a pre-authorization requirement on all mental health substance use disorder inpatient benefits. You always have to get it pre-authorized in order for the benefit to get paid. What you then have to look at is, okay, what are the factors used in creating, or what's the why behind applying this type of pre-authorization requirement? Is it because there's a high prevalence of fraud? Is it because, medical journals say that outpatient visits are actually more appropriate as a first level treatment for this benefit? It's that medical science in the background that you need to look at in determining why that non-quantitative treatment limitation is being applied to those benefits. And then you look at the various sources that you garner that information that support your determination that NQTL is appropriate because of that why reason. And then you look at that medical surgical side and say, okay, do we apply it similarly on the medical surgical side? It's not straightforward. I'd argue this is a pretty subjective analysis, and NQTLs have been a source of angst, I think, both for plan sponsors and the Department of Labor for some time, is how do we look at this and how do we even find these? Because these NQTLs, some you might be able to physically see in a plan document, like a pre-authorization requirement. But some of these non-quantitative treatment limitations are things that are happening behind the scenes. Like, how is a medical necessity criteria created? If you go on an insurance carrier's website, and I learned this at the Department of Labor, They have a massive quantity of medical necessity guidelines, if you will. So, when is it appropriate to have a certain heart procedure done? When is it appropriate to get inpatient treatment for an eating disorder? And they have kind of a bulleted list of how you get to that level of care. It's pretty robust, and it's all going on behind the scenes, and it's not readily accessible in a plan document, something that the carriers would or TPAs have behind the scenes. So this has always been an area of concern for the Department of Labor. And then it became even more heightened most recently with the passing of the CAA. So we'll go to the next slide and say, okay, Consolidated Appropriation Acts, again, highlighted this issue in general. And I'd argue mental health benefits have been a growing area of concern, not just from the Department of Labor's standpoint, but if you think about it politically, mental health is a focus of a lot of attention in the media. If we go into election years, the mental health of society coming out of a COVID pandemic here, how has that been impacting people? Mental health care is becoming a hot topic across the board. And I'd argue it has been for some time. So what did the CAA require? So again, mental health parity, not a new requirement, but what the CAA did was say, hey, plan sponsor, upon request, you must provide the Department of Labor with a comparative analysis of all the NQTLs that are utilized in the plan benefit determinations. The NQTL analysis needs to include the information I have listed there, which I'm not going to read bullet for bullet, but highlighting what we just discussed is what are the justifications for applying these NQTLs and what are the NQTLs or the similar limitations that are applied on the medical surgical benefits in that classification. How do you show that we are not being more strict or more restrictive on these mental health benefits? And so the CAA said you have to have this comparative analysis. They put a timestamp date of February 10th, 2021. Former DOL Rory Akers says, the Department of Labor could have always asked for this level of analysis, but this added more of a formality to it. It's got to be, this comparative analysis. And because of that, it garnered a lot of questions from both carriers and employers, plan sponsors alike. Okay, how do we do this? So we're going to go to the next slide here. The DOL has provided some guidance through the form of an FAQ, Part 45, to help highlight what they're looking for in terms of this comparative analysis. What the Department of Labor has not provided to date has been a sample, if you will, of what a comparative analysis would look like. But they have provided some insight. They have had a self-compliance tool that's out there for mental health that they've walked through and said, these are the criteria that we are looking for in terms of it. And again, it gets back to that justification and the support for having that sort of limitation on these benefits that you're looking at. The one thing that was highlighted, though, in that FAQ is what the DOL does not want to see. And they don't want to see vague language like we rely on our medical necessity determinations to determine if that claim should be paid. They don't want to see that. What they want to see is the behind the scenes. How are those medical necessity determinations made? How are they monitored? Do they change with the evolution of science, right? So at one point, a certain treatment might have been experimental or investigational, but in the following year, it's actually the appropriate treatment and it's been certified. Do you update your medical necessity determinations in light of these advancements? They want to know if you say we have a medical committee looking at these type of issues, they want to know who's on that medical committee and what are their credentials that make it appropriate? How often do they meet? They want to know the ins and outs. And part of me wants to say it's because the Department of Labor doesn't have a lot of knowledge in this area. They're putting the burden on plan sponsors to get them knowledge of this area to make the case as to where there might be issues with parity analysis. The other thing that the FAQ highlighted was areas of focus. So they're looking, pre-authorization requirements have always been an interest of the Department of Labor. This concurrent review process, which is similar to pre-authorization, but if you have to get it reapproved for a 30-day treatment, how does that process work? Is it you have to get approved every 30 days for mental health, but only 60 days for medical surgical benefits? How does that line up? The other issue that they have been focusing on is networks. These are where carriers and TPAs have a lot more knowledge for a plan sponsor. So we're going to quickly go through the next slide. We've got all of these requirements from the Department of Labor, but there's still a challenge here. And the challenge is most plan sponsors don't know all of these behind the scene NQTLs that apply to their plan. The reason being, a lot of plan sponsors will sign on to what I call the prototype plan or the standard plan designs of TPAs and carriers. They'll say, listen, we just adopt your plan. We don't make any modifications. So carrier TPA is the one who says what claims require pre-authorization. They apply medical necessity. So the plan sponsor, who's ultimately responsible for this, doesn't have the information they needed. And so what is been the process we've been going through the past year with our partners has been engaging with TPAs and carriers to say, okay, what level of information are you providing our clients to help them with this analysis? Because despite it being a plan sponsor obligation, the angst is a lot on the TPA and carrier to explain the rationale for a lot of these. The only caveat I'll say is if we do have a plan sponsor who makes variations to that plan, that prototype plan that they could adopt, that is something that the plan sponsor is likely going to be responsible for defending, is if they say, listen, we're a hospital. We don't want any pre-authorization requirements for services obtained in our hospital. That's something they would say the plan sponsor likely has to. So we'll go to the next slide. Highlighting what I said earlier here, though, is the DOL hasn't provided a sample of what they want to see. So what we've been seeing is a lot of variations of what is, quote, a comparative analysis. I've seen 80-page grids. I've seen detailed memos regarding pre-authorization and concurrent review. It's depending on what carrier you're looking at as to what they're willing to provide at this point. So the one thing I do like to tell plan sponsors, because I think it's kind of a silver lining, is we all know that the plan sponsor at the end of the day is responsible, but the DOL does understand, and I've had conversations with them in the past few months. They do understand that a lot of this information and a lot of these determinations are at the TPA and carrier level. So if a plan were to have an issue, they would know to push the carrier TPA in that regards. Okay, and I know we're at time here. I'm going to highlight a couple of areas of focus based on DOL investigations, and we'll go through them quickly. I'm really sorry. So things to highlight here: ABA therapy exclusions. I think this might be the one I'm going to highlight for you because we have seen that Department of Labor actively targeting plans that have these ABA therapy exclusions. So, for the longest time, this was a question like, does a plan have to provide ABA therapy for treatment of autism in their benefits from a mental health parity? And what the rules generally say is, listen, a plan doesn't have to provide every treatment available for every diagnosis covered by the plan. However, if you're going to exclude ABA therapy, you have to be able to justify that going through that NQTL analysis. So is your justification because we cover a lot of other services that are more effective or just as effective? That would be a justification to make. Do we have evidence that ABA therapy is overly utilized? And so we, in fact, cover physical therapy, speech therapy, and I'm not an expert in ABA therapy, but I know that these are components of it. What do you provide in terms of treatment for autism on par there? Now, the other thing to keep in mind in terms of ABA therapy is you would have to analyze ABA therapy exclusions, but if you, a plan sponsor, would want to exclude coverage of autism outright, that would be something the mental health parity rules would allow for. Now, my one caveat here is state laws may vary. There are actually a number of states that are now mandating coverage of autism and ABA therapy. Now, if you are familiar with ERISA preemption, if you have what we call a self-funded health plan, you are afforded what we call ERISA preemption rights, which means state laws are basically shielded by this ERISA argument, right? So you're not required to comply with those type of insurance mandates on the benefit plan. But that is something to consider. Generally speaking, is if you have a fully insured plan, you can't likely go to the carrier and say, I don't want to cover autism, because a lot of states will mandate that. But mental health parity laws don't require coverage of autism in general or any benefit requirement. But if you're going to exclude a treatment of something you do cover, like autism, you've got to go through the analysis. Pre-authorization and concurrent review. When I was with the Department of Labor, we were developing these investigative plans. I think a lot of carriers and TPAs have gotten on board. When I started with the DOL, it was all medical, surgical benefits, didn't require medical, or only inpatient benefits would have to get pre-authorized for medical, surgical, but all mental health, substance use disorder benefits had to get pre-authorization before getting coverage under the plan. That on its face is going to be problematic. We don't see that as much happening here. What the DOL has highlighted recently, though, is if there's an intermediary between a provider and the plan claims administrator, if mental health benefits have to go through a separate hoop, so they have to go through almost 2 levels of authorization, that's going to be problematic. So that's something to look at is behind the scenes is how many layers of pre-authorization requirements are actually being applied to this. We'll go to the next slide. Network adequacy. I think this is going to be a growing area of concern with the Department of Labor, because what they are finding is, a plan on its face could say we cover the same coinsurance rate, both for mental health disorder benefits in network as we do for medical, surgical in-network benefits. But if you go behind the scenes, what they're starting to understand is there may not be a robust network of mental health, substance use disorder providers in that in-network. If I were with the Department of Labor, I might say I'd highlight hospitals with domestic tiers. This is an area that they started to provide some guidance on. If you have a domestic tier, you have to consider, okay, do we have enough mental health providers in that domestic tier if it's getting a better benefit at that level? So those are things to consider is, are there enough providers in that network to provide the services? They are also starting to highlight, and this is where I think a lot of us will have to learn. But when these carriers and TPAs are contracting with these providers to provide in-network benefits, what are the reimbursement rates? What are the contract requirements in order to become in-network? And are they being more strict or more stringent on mental health providers? Again, highlighting that's obviously something the carrier or TPA would have to focus on and to help assist with in terms of justifying their network. So those are what we're seeing the Department of Labor look at more and more. I'm going to wrap it up here. We're not going to go through all these slides, but I do want to say we have seen a lot of letters from the Department of Labor with regards to these mental health investigations. My gut tells me that they have cases open in every regional office, and the thought is they have to open a certain number every year. The good thing is if they open these cases, we might get more clear guidance as to what they want to see. But I do think that that's not going to slow down in the next, year, 2 years, 5 years even. I think this will continue to be an area of focus for the Department of Labor. So my advice to clients to date is let's get our ducks in a row. Let's make sure we have a comparative analysis to provide to the Department of Labor should they come knocking, because odds are, if they stick with the trajectory they're looking at, my gut tells me they've got an idea that they can open up investigations on all of these, all plans in the nation in the next decade to look at their mental health benefits. So something to keep in mind, start asking questions of TPAs and carriers to help highlight, okay, what do we need to understand with this comparative analysis?